Hello, and welcome to another podcast here with ACRO, the American College of Radiation Oncology. My name is Dr. Simon Brown, and I am a radiation oncologist at the West Michigan Cancer Center. I'm delighted today to be sitting here with my good friend and colleague, Dr. Brandon Mancini, the medical director at BAMF. Today, we'll be discussing general topics within the field of theranostics, and hopefully this conversation will be very informative for you. Of course, our goal is always to provide content to the community so we can be better people and better physicians for our patients. So with that, I'll hand it over. Brandon, how are you today?
Good. How are you? Thanks for having me.
Yeah, definitely. We're really excited to have you here to talk about Theranostics. Just brief kind of overview history of what you do here and how long you've been here. I think you said you were here for almost 2 years now as the medical director.
Yeah, that's correct. Yep. I joined BAMF Health back in March of 2022. Was a radiation oncologist by trade after graduating from Yale in 2016, out in clinical practice for the time prior to this transition. Kind of started transitioning to interest in gastrointestinal and genitourinary malignancies. Had a lot of the molecular imaging come up within practice, and kind of got a keen interest in some of the innovative techniques coming out in the space of molecular targeted radiation therapy, theranostics, etc., and made that transition to BAMF.
Sure. Where did you first hear about theranostics and radio? Yeah, where did you first hear about this?
Yeah, so really in the practice of genitourinary malignancies, just treating my prostate cancer patients, as molecular imaging, as PSMA PET got approved by the FDA, and that was starting to become a lot more popular and effective in kind of maximizing knowledge base and patient characteristics prior to initiating treatment. Really was turned on from the imaging standpoint first because of the precision-based oncology that it promotes, and kind of got down that rabbit hole of learning more about the therapy side, and was intrigued by kind of the approach and how it's truly precision-based therapy at its finest.
Sure. And being here almost 2 years, so how many cases have you seen since you've been here?
Yeah, so we have treated roughly 600 patients or 600 cycles of therapy since initiating services here, and
that in comparison to other centers and so forth, is that about what all other centers have done, or you guys here have done more, less?
I think we're definitely one of the busiest centers within the country. I think being a theranostics only center, we specialize in maximizing the potential of the therapy and taking a unique approach to therapy. So we're definitely in the kind of upper tier as far as volume goes.
Wow, very good. Well, lucky to have you here. Thanks for that. So just to start off, just a brief overview of like the radiopharmaceuticals that are available. What is available and what are the indications?
Yeah, that's a great question. So there's two major medicines available right now that are both FDA approved and in the national guidelines. One is Pluvicto for prostate cancer, and specifically that's for castration-resistant metastatic prostate cancer in patients that have received prior novel anti-androgen therapy, continuous androgen deprivation therapy, and taxane-based chemotherapy with a PSMA positive metastasis or more on a recent restaging PSMA PET scan. So that's kind of the full indication for that therapy at the present time. There's also Lutathera. Lutathera is for metastatic gastroenteropancreatic neuroendocrine tumors.
Sure.
And that's typically grade 1 and 2 tumors who have been on continuous lanreotide but then had progression of disease. And those patients need to have SSTR positive metastases, which is accomplished by doing a dotatate PET CT. So two drugs, a couple of indications, some prerequisites to qualify.
Sure.
But a lot of promise.
So they sound like they're more like second line treatments from your upfront standard cancer treatments, correct?
Yeah, definitely in the prostate cancer space, one would argue even third or fourth line, because of the need for ADT, novel anti-androgen, and taxane-based chemo. Kind of more toward the end of viable treatment options there, and definitely second line would be appropriate for neuroendocrine.
So second line, okay.
Yeah.
No first line indications yet.
Yeah, and that might be changing. NETTER-2 was a randomized trial that was recently presented for grade 2 and 3 gastroenteropancreatic neuroendocrine tumors who were randomized between receiving lanreotide at an increased dose versus lanreotide with upfront Lutathera, and that has shown a lot of promise as far as the preliminary presented results as far as progression-free survival and overall response rate for upfront therapy. Mm-hmm. So there's a lot of excitement within the space that this may proceed to be a upfront indication or a first-line indication through FDA approval and in the national guidelines for these types of patients.
That's good to know. What has been your experience with the patients as you deliver these therapies?
Yeah, no, it's been amazing. I think people are very intrigued, rightfully so, about targeted medicines. And this is truly a see what you treat what you see phenomenon, right? The PET scan identifies the target. The therapy only goes after that target. And your body kind of filters out any excess medication. And it does that without significant sequelae or significant outward side effects. We even have patients question if we actually gave them any medication, which is the best feeling in the world, because it just means that they're tolerating it very well, and we have the confidence of medicine getting to where it needs to go.
Oh, that's great. So listening to you and talking about so the wonders of Theranostics and what it's doing for our cancer patients, as a community radiation oncologist, if I wanted to bring this to my community, how would I go about doing that? Is there any resources, or is a facility like BAMP available to provide guidance for something like that?
Yeah, I think both are definitely applicable. You have great resources in actually the pharmaceutical industry in and of itself. So both drugs are produced by Novartis or AAA, and so they have a whole patient access team and a team that would assist with starting up one's own Theranostics center. Both the Society of Nuclear Medicine and Molecular Imaging, so SNMMI, ACRO, are becoming a lot more involved within the Theranostics space in organizing resources and educational opportunities of the who, what, where, when, why, and background information as far as getting such programs off the ground and started. Here at BAMP Health, we do have opportunities for partnership via various modalities, whether it's joint venture or opportunities within the space in other capacities. So yeah, I think there's a lot of resources that continue to evolve to make this reachable for any clinic.
Yeah. And you mentioned joint venture. Do you have an idea of what a cost would be? It seems like it'd be something you would have to do a joint, because I'm in the community here, and it seems like that's something that you would need excess funding for. Is that true? Or
that's a great point. I think a lot of centers we've seen, they kind of reorganize or restructure a space that they already have. So obviously getting involved, the physicist, radiation safety officer for your institution or hospital or center is quite important, because there are a lot of radiation safety protocols and aspects that need to go into decision making. For a brand new footprint, like a new build or so forth, whether that's involved at a higher level institutionally or within interest from a particular clinic or center, definitely some sort of funding would be appropriate, and we've seen other facilities that have planned budgetary inclusion of a Theranostics center or some type of modifications to infrastructure for fiscal years in the future. And so I think it just depends on the patient need, the desire of the radiation oncologist to become involved, and the support from the hospital, center, or institution as to kind of what they need to do to set up the appropriate infrastructure, staff, team, and facilities to be able to carry this out at their level.
And so you would need a radiation oncologist. I know nuclear medicine also participates and doing Theranostics as well. Is it a joint venture between the two specialties? Can one operate independently? What has been your experience?
Yeah, I think the vast majority of academic centers seem to have nuclear medicine as the primary team or department that is leading the charge. I've also seen institutions where it's a combined effort between radiation oncology and nuclear medicine. And then most importantly for a lot of us in the community, radiation oncology is kind of taking the bull by the horns and being the leaders in that process, because obviously we're treating with radiation therapy on a daily basis, and we have the clinics and the patients that kind of meet the criteria for these types of therapies. So I've seen it in multiple different fashions. I think collaboration is by far the most important aspect. Communication, team-based approach, kind of getting all players involved that have just true interest in Theranostics is going to be the best kind of combined effort to kind of outlay a program very nicely.
Yeah, very nicely. Well said. So, listening to you talk about this, what are some of the pitfalls that could come from trying to start your own theranostic centers, but just in general? There's maybe supply shortages with radiopharmaceuticals. What have you seen, and what's your experience been?
Yeah, I think there's a very well publicized supply shortage for Pluvicto earlier in 2023, and Novartis and AAA have largely been working toward very consistent and persistent and reliable production and distribution as they've onboarded a facility in New Jersey and just had recent FDA approval for their facility in Indianapolis. So I think as far as the United States goes, they went from one center when Pluvicto was first approved in March of 22 out of Italy, and now that's very soon going to be 3 separate centers for production and distribution, which is amazing for patients and providers to be able to get this medicine to individuals. So I think that is going to be a more consistent approach when it's all said and done. As radiopharmaceuticals advance and there's more unique offerings that potentially would be FDA approved, you do have more difficult production and supply issues potentially that could arise. And so you see a lot of capital being invested into companies producing unique radiopharmaceuticals that are showing a lot of promise to try to get ahead of that potential shortcoming that could be anticipated.
How do you guys navigate the supply shortages?
Yeah, I think in general, being proactive. So again, because we are a Theranostics only center, we have a team dedicated to adjusting doses if patients aren't able to move forward with a therapy. So if they're scheduled later this week, but they have a lab abnormality or something come up, we will repurpose that dose to another patient that might be waiting for a couple of weeks, as long as insurance approval has come through and et cetera. And so I think just being active within the space. So that's one thing also. The ordering system has largely improved and it's become a lot more user friendly over the last year and a half, allowing that type of opportunity so that patients aren't waiting weeks and weeks to get this type of therapy.
Okay, very good. So I know you mentioned earlier on, that the patients, it seems to be well tolerated. Well, what side effects, would you expect to see or have you seen, from these treatments?
Sure. Yeah. So for Pluvicto, just as the most common type witnessed side effects would be, patients can have a bone pain flare if they have bone pain coming into initiation of treatment, and that typically would happen the evening of treatment and can last for a handful of days thereafter, which then would be anticipated to improve. Some patients have a little touch of nausea or kind of decreased appetite the evening of treatment or the morning after treatment, which can be treated with antiemetics or just kind of a very simple diet and made to pass. In the intermediate time in between cycles, we monitor patients' hematologic and chemistry parameters to make sure that there's no abnormalities. But as the VISION trial and others have demonstrated, there can be a trending down of certain hematologic parameters like hemoglobin, platelets, and white blood cells that need to be monitored over time. While it's rare, a minority of patients might need to have some sort of treatment delay to allow any type of nadir or any toxicity to resolve along those lines. And then Pluvicto, one of the hot topics is kind of the uptake within the salivary glands as well. Dry mouth on the VISION trial was reported at about 39%, and we've noticed in practice that it tends to be at least reported by the patient in about a quarter to a fifth of the patients. And so those are kind of the main ones. The biggest thing is, despite potential side effect profile, patients' quality of life tends to be stable or improving as long as the medication is effective, and that can be a lot different compared to things like chemotherapies or non-specific therapies.
No grade 3, grade 4 toxicities.
Yeah, a lot of the reported grade 3, 4 would be asymptomatic drops in blood counts, and that's exceedingly rare. We have seen some increased toxicity in patients that have diffuse bone marrow involvement with previous Xofigo use or multiple previous lines of therapy, so unique scenarios. But this is not a general course for most patients, which is great, and very, very thankful for the patients. And then Lutathera is quite similar as far as monitoring the blood counts. Obviously, this is a radiation medicine, kind of exposing the total body to some low-dose radiation for a period of time. They can get some nausea with the amino acid infusion that's required for kidney protection when you give the Lutathera. But again, outside of that, it tends to be asymptomatic changes in blood counts that don't typically require things like delays in therapy, transfusions, or anything more.
Oh, very good. Thanks. Okay, I'm going to wrap up here pretty soon, but a few more questions for you. Where do you see radiopharmaceuticals in the next 5 years, and what excites you?
Yeah, I think it's a rapidly evolving kind of field in general, which is very exciting in and of itself. There's predictions of 10 to 15% growth per year over the next decade within the field. That's the same current medicines or targets getting better, more specific, more precise. Whether that's right now we give treatment once every 6 weeks for 6 times at a certain dose. Is that the right dose? Is that the right interval between treatments? Is that the right number of total treatments? I see incorporation of dosimetry, which is music to the ears of many radiation oncologists, because we stop at 6 because there's anticipated amount of absorption to the kidneys or the salivary glands or to the bone marrow. And so getting more precision based on facts from dosimetry for this precision-based therapy is incredibly exciting. I kind of touched on the more advanced radiopharmaceuticals, more aggressive radioisotopes like the alphas, whether that's actinium or lead or astatine, and those pack a bigger punch and they might have bigger toxicity or more toxicity as well. So navigating incorporation of those therapies. Maybe it's combined modality therapy, maybe it's some chemo or some immunotherapy, radiation therapy with the targeted molecular targeted radiation, moving it earlier in the line of therapies, and then most importantly, more targets and more cancers. So whether it's a more generalizable target that applies to many solid tumors, or if it's more unique like PSMA proteins that are identified that have similar characteristics and retention of the medication. We're just at the very infancy of Theranostics as far as advancement within the field. And so every day something new and something different and something more advanced. And so I think that's what makes it remarkable. And radiation oncologists are literally the most well-trained and the most appropriate background and physicians and practitioners to be able to help patients at their utmost because of the understanding of oncology, dosimetry, and radiation principles. And so it's an exciting time for the field.
Do you have any final thoughts you'd like to share with our listeners?
Yeah, I think Theranostics is very important. I think it's going to be a mainstay of therapy and continue to evolve. It's exciting to be involved with this type of field and incorporating this type of therapy in the field of radiation oncology. And it's exciting to see how ACRO and other medical societies continue to work together to make it safer and more effective for our patients. And we learn together. So it's going to be an exciting future.
Well, hey, Brandon, I can't thank you enough for taking the time to spend with me today, to spend with ACRO. I sincerely appreciate your time, and ACRO appreciates your time and contribution to the community.
Absolutely. I appreciate it very much.
Thank you.